Okay, so we are doing potpourri today. Welcome to everyone joining us online, and you can't see anything because of a big Panopto thing in your way, so let's move that. Okay, so let's go ahead and start. So, Kathy, you want to start us out here?
Sure. Superficial perivascular inflammation, predominantly lymphocytes, but there's a lot of eosinophils.
Lots of EOs.
I'm thinking of urticaria. The collagen looks a little edematous.
So a later stage of
Yes.
urticaria is certainly in the differential. Acute stage of urticaria, you see just neutrophils stuffing the vessel lumen. Later stage of urticaria, the neutrophils leave the vessel wall, but remain intact. There is no karyorectic debris, which is different from leukocytic classic vasculitis, where there would be karyorexis. Here, all neutrophils are intact. So consistent with urticaria. What other sorts of things fall in there? Drug, bug, fight, id. So drug eruptions can give you a dermal hypersensitivity response. Bug, one of the hints is it's often a deeper infiltrate and often with endothelial swelling occluding the lumen. We really don't see that so much in this one. And then dermatophyte, always remember that. There's not a whole lot of corneum to look at in this case. It's up above. There's not a layered corneum, basket weave on top of compact, which is a helpful clue to dermatophyte. And then id reactions can look like anything. So, okay, very good. Dermal hypersensitivity, and this one was actually later stage urticaria. Let's make sure we are colored. We're a little bit off. There we go. We'll be crisper now. So there's a band-like lymphoid infiltrate. Not so much lichenoid interface dermatitis, but certainly a band-like or lichenoid infiltrate. So lichenoid can refer to a band-like infiltrate or to interface with destruction of the basal layer. In this case, we have only the band. And then there's a crust and a little bit of acantholysis just above the basal layer. Let's look at our other piece. And in the other piece, we also have a little acantholysis, but it's higher. So in the one piece, it's more like at a vulgaris level. At the other one, it's more like at a foliaceous level. There may also be just a little bit of spongiosis focally, sometimes some EOs, some dyskeratotic cells. So focal acantholytic dyskeratosis or Grover's disease can give you a mix of all the different patterns in the same specimen. So it looks like pemphigus in one, like vulgaris in one, and like foliaceous in another, maybe like Darius in a third area. You get to pass or play.
Can you see nodules in the dermis?
So very good. So a nodular dermal infiltrate,
And
maybe somewhat wedge-shaped.
you see them melanocyte?
Yep.
And
A single population of melanocytes or a mix of small and larger melanocytes? clue, it's always the second choice. So mix of small and larger. You have two populations mixed together. Sclerosis of the dermis. Ropey collagen newly synthesized. So it has its own stroma. In anything that resembles a blue nevus, that's a very good sign to have its own ropey stroma. One of the things that you can do is do diffraction. Let's go down to 2x. And whereas the normal collagen is quite bright, newly synthesized stroma is dark. That's what it should do in a benign blue or combined nevus. If everything is equally bright and you just have trapped pre-existing collagen, that goes with blue nevus like melanoma of skin or uveal melanoma of skin. So putting all that together, this is probably a combined nevus. Great.
Got a bunch. There's a lot of edema in the papillary dermis.
A lot of papillodermal edema, absolutely.
It looks like those are lymphs.
There are lymphs, and then there's some red
Also
guys
some
in here.
EOs.
Lots of EOs in addition to the lymphs.
Um,
Tell me about your vessel lumen.
I don't really see it, so maybe
Hmm.
thinking about arthropod.
Yeah, endothelial swelling, so arthropod sort of goes to the top. Well done.
So lots of little blue nodules. Looks like little tumor islands. If there's some palisading, I'm thinking more basal cell. If there's like little papillary mesenchymal bodies, I think more trichoblastoma.
And this one kind of radiates outward. Pink strands, blue buds, horn cysts,
Maybe like infundibulocystic.
like infundibulocystic BCC or basaloid follicular hamartoma, both of which can look like this, and you really need history and physical exam to tell them apart.
So we have a punch biopsy, some deeper infiltrates around the adnexa.
And so it's around what portion of the adnexa?
I mean, they look like hair follicles.
And what bit of the hair follicle?
Like the bulb.
The bulb! So what owns the bulb in terms of infiltrate?
I mean, you could think of alopecia areata, and then you have to think of syphilis if you think of
And those are the key two, right? Alopecia areata and syphilis. What's this?
it looks like catagen.
Catagen, 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 catagen. They're all catagen, which is also typical for alopecia areata, syphilis, or trichotillomania. But trichotil will not give you the deep lymphoid infiltrate around the bulb. Another helpful feature for alopecia areata is the cyst-like dilatation of the follicular infundibulum filled with keratin. In transverse sections, Lila El-Shabrawi referred to that as the Swiss cheese sign as you get up really close to the epidermis. But that's a helpful feature also of alopecia areata, to get that dilatation of the infundibulum, the multiple catagen hairs, and then the infiltrate around the hair bulb.
Can we see the follicle is in the intelligence?
See the catagen follicles, you mean?
Yeah.
You tell because they have the accordion-like infolding, and if you go on higher power, you will see lots of dead reds, which means it's a dying programmed cell death leading to a shrinking follicle.
So we have a mid-deep dermal infiltrate with lots of ruby collagen. And
And the infiltrate is it
maybe lymphocyte.
nodular? Is it interstitial?
I would say nodular. And there's
And it
Like a
wraps
granule.
around collagen bundles, right? So
Yes.
it's interstitial granulomatous infiltrate.
mhm,
And then what do you call it when it kind of forms a ring like that?
granuloma.
And what kind of granuloma?
This one is
Kind of forming a ring around the side of something? Palisading
palisading.
granuloma, and then what's in the center? What's that?
Mucin.
Mucin in the center, so what do you think?
GA.
Granuloma annulare. Very good.
Pretty big infiltrate.
Pretty big infiltrate.
Those
What kind of cells?
there's EOs.
EOs and what are all these little fragments? Neutrophils with karyarexis. And then tell me about the walls of the vessels.
Almost looks like wrap around.
Yeah, like onion skin fibrosis. So what do you think this is? So do you think this is acute leukocytoclastic vasculitis or a very, very chronic fibrosing leukocytoclastic vasculitis with eosinophils?
That one.
The second one. Okay. So do you know any very, very chronic LCV with EOs?
Yeah, the ED.
So on the face, granuloma faciale, and elsewhere, erythema elevatum diutinum. So this would be very good for EED. EED, erythema elevatum diutinum, neutrophils, karyarexis, eosinophils, and onion skin fibrosis, layered fibrosis around the vessels. I'm telling you, it's a very, very chronic leukocytoclastic vasculitis.
So it's a really long, narrow shave. Looks like
Very long, narrow shave.
it's a proliferation of one, like an DEJ.
Yep. So what's your differential?
I think that it's melanocytic. I was thinking like Clark's.
Yeah, so Clark's versus worse, right? What are those pigment-bearing cells that are all the way up into the corneum?
Is that pagetoid scatter?
That's pagetoid scatter. And it's off to the periphery of the lesion. It's purely junctional. It's moderately broad. It's on sun-damaged skin.
MIS, at least.
That sounds about right.
So we're on pretty sebaceous skin, probably like on the face.
Yep.
I think there's a melanocytic proliferation in the upper dermis,
Yep.
and maybe a little bit in the epidermis as well.
So there's definitely melanocytic proliferation that looks fairly bland, a zone of fibrosis, and then a junctional proliferation that in some areas is nested, but in other areas not at all nested.
So maybe like a regressing melanoma.
Regressing melanoma, or what else would give you a totally benign nevus, a zone of fibrosis or scar, and then a junctional proliferation that may be confluent.
Like if you biopsy.
Recurrent nevus. So recurrent nevus, you can have confluence at the junction, but then there's a scar and the residual completely benign nevus below.
Looks like we have
Yeah, let's find another piece. Yeah, that's good. Okay.
a papule, sebaceous glands.
Okay, so maybe we're on the face, and there's a little papule, and the papule is composed of,
Some vessels,
and
some fibrosis, and some stellate fibroblasts.
so this is
Angiofibroma, fibrous papule.
angiofibroma fibrous papule. Unless you know something else that is angio and fibro. So angiofibroma, which kind of describes exactly what you see. Epidermis. So dermatofibroma, you have collagen trapping, epidermis, overlying acanthosis, lacy-like extension into the superficial fat. So name 3 proliferations that will have overlying acanthosis.
DF, Spitz, and granular cell tumor.
DF, Spitz, and granular cell tumor. Someone pass the easy button.
It's in China now.
That was easy.
Actually, I did buy more easy button. Actually, that's a lie. My wife went out and bought more. This is probably not a fair slide. We're going to skip that.
What was that?
There's a neutrophilic reaction to chemo. History would be kind of key to that one.
Thick impetiginized crust.
Yep. Thick scale crust. And then what's under the thick scale crust?
Kind of spindly-like cells.
Spindly-like cells.
Slammed up
Are they
against that
nice,
dermis.
nice, kind, happy, normal cells?
Pleomorphic and hypochromatic.
Pleomorphic, large, hypochromatic. So tell me about these atypical spindle cells slammed up against the epidermis.
They're differential, or slam differential.
So the differential spells slam, which is?
Squamous cell carcinoma, leiomyosarcoma, AFX, and melanoma.
Okay. So do you want to get any stains?
Sure, let's do it.
Okay. Name them. What do you want?
Like a pan-keratin or a...
So a pan-keratin or a P63 or an AE1 and 3, and those are negative.
An SMA or...
SMA is probably too sensitive. We've stopped doing those. So more like Desmond or Cal Desmond these days, and that's negative.
And then like a MART1 or...
MART1, how good is that in spindled melanocytic proliferations? Not very good. So like a SOX10 or S100, which would still be reliable in spindled. HMB, totally unreliable when it's spindled. MART1 like 50-50, and SOX10 and S100 very reliable and spindled. Negative.
So looks like we got an AFX.
Probably atypical fibroxanthoma. And some people will do CD10 or procollagen 1 for confirmation, but it's largely just a diagnosis of exclusion by excluding the other atypical spindle cell tumors.
Alright, so there's dense infiltrate, looks like around the vessel, a lot of pigment.
Yep.
So I'm not sure if or where that pigment came from, if it's like a tattoo reaction.
Yeah, so first question is the pigment brown?
It's like black.
Looks like black. So you're absolutely right. This is a tattoo reaction. Well done.
That was easy.
So there's spindled cells kind of intercalating between collagen bundles.
Yep.
It's not really well demarcated. The rolling epidermis looks fine. I don't know if there's a good
Fine effaced, fine thick, fine normal.
Not effaced, maybe mildly acanthotic.
Mildly acanthotic. You've sort of lost your reedy pattern and you're going towards a plate-like acanthosis. Name 3 tumors with overlying acanthosis.
So dermatofibroma, spitz, and granular cytoma.
And which one is this?
The dermatofibroma.
Yep.
Superficial fibrosis.
So you have a little bit of compact hyperkeratosis. You have some pigment incontinence suggesting there's been damage to the basal layer. And in fact, where is your basal layer? Or is it gone? So interface change. And this is in the upper back. Someone with violaceous eyelids, upper back, over the knuckles, dermatomyositis. And dermatomyositis is often a very, very subtle late stage interface dermatitis. So, fairly normal except for a little bit of an interstitial infiltrate. But when you look at the deeper biopsy, tell me the difference between this collagen up here and that collagen down there.
Collagen balls.
Yeah, or very, very hyalinized. So this is fairly normal. And then this very thick hyalinized collagen with loss of space between the collagen. So what would give you a lymphoid infiltrate, nodular, perivascular, sometimes a little interstitial around the collagen with hyalinization of the collagen? Yeah, morphia spectrum. So morphia scleroderma, and in particular morphia profunda, because here it's particularly deep, the sclerosis of collagen. So well done.
So we've got a deep infiltrate. There's some giant cells in there.
Yep, definitely giant cells. So highly inflammatory, lots of giant cells. What are these little things?
Like keratin debris?
Like keratin flakes. So this is?
Like a cyst?
Yeah, ruptured cyst.
It's like deep.
Yeah.
So it's pretty bloody.
Bloody, which may be the lesion itself, or maybe your injection.
Okay.
The patient bruised a little bit.
There's some spongiosis in the epidermis.
Is this an acute or chronic process?
Chronic.
Chronic, you have a compact corneum with or without parakeratosis?
With parakeratosis.
With parakeratosis. Tell me about your basal layer.
So it looks like there's maybe like some There's some dead reds in there.
Some dead reds. So what kind of, is it more spongiotic or more interface with the dead reds?
Actually more interface.
So it's more interface with dead reds. It has a compact corneum with parakeratosis. And then what's that binucleate red thing in there?
A little EO.
Eosinophil. So you've got an interface dermatitis with EOs and parakeratosis.
Like I guess you could think of like, I guess arthropods more acute. It could be like some sort of chronic drug.
So what kind of drug you said interface with dead reds? Lichenoid drug. So lichenoid drug eruption has parakeratosis, which LP does not, has EOs, which LP does not. Well done.
Looks like we pretty deep down to the back.
Pretty deep, lots of inflammation.
Yeah, lots of inflammation.
And what is this structure here?
I think it's a vessel. So
And what
we
kind
can
of vessel? Given the
perhaps an
pattern of the
artery.
muscularis.
Looks like an artery.
Like an artery or arterial. So what beats on arteries or arterials like
Pretty
this?
deep down, so PAN.
Polyarteritis nodosa. Very good.
So there are very sun damaged skin with a lot of solar elastosis. There is a P follicular infiltrate.
And where around the follicle? Is it infundibulum? Is it bulb? Or is it isthmus in the middle?
In the middle, isn't it?
Isthmus. Tell me about the follicles. Keratin plugging
Plywood.
of the follicles, and then eccrine coil involved with the lymphoid infiltrate. So patchy lymphoid infiltrate loves the isthmus, follicular plugging, eccrine coil involvement.
LPP.
So
Lupus.
lupus, LPP hits here, lupus hits in the middle, and does the eccrine coil. So lupus.
Looks like there's inflammation. Looks like there's some sort of proliferation in the epidermis.
Some kind of proliferation that makes brown stuff.
Yeah, so melanocytic.
Melanocytic. And is it exclusively tips and sides, or is it up in the arches?
Within the arches.
So what kind of thing do you know that's purely junctional on sun-damaged skin and loves the arches? That would be your arch enemy, right, which is melanoma. So tips and sides should be nevus. It even sounds friendly. Tip of the reedy to you this morning, right? Whereas the arches reminds you of your arch enemy, melanoma.
So it looks like maybe a dermal. I can't tell if it's proliferation or inflammation, but you have also some superficial perivascular. It looks like lymphocytes.
So superficial perivascular lymphocytes, and then
So
does this displace collagen or does this wrap around collagen?
wraps it around.
So is that more likely a tumor or an inflammatory infiltrate?
Inflammatory. It looks like granuloma. Maybe.
Looks granulomatous. And is it top to bottom, side to side, or is it focal?
Focal.
So what would be focal, interstitial, granulomatous,
GA.
GA, interstitial GA?
So there's acanthosis.
Acanthosis, and above that,
I think some parakeratosis.
and hyperkeratosis. So hyperkeratosis, some parakeratosis, acanthosis. Is your papillodermis normal?
No, it's more red than usual.
Yeah,
and
fibrotic, so, and prominence of vessels, so papillodermal angiofibroplasia.
I think this is psoriasis.
So psoriasis, do you get thick or thin suprapapillary plates?
Thin.
And in this case, you have thick. So not so much psoriasis. Psoriasis also doesn't give you angiofibroplasia of the papillodermis. So what would give you hyperkeratosis, acanthosis, and angiofibroplasia in the papillodermis?
Like stasis stasis would give you angio.
Gives you nodular-like, cannonball-like angioplasia. With this is more like lichen simplex chronicus change. Sometimes you get vertical streaking of the collagen. Other times it's just angiofibroplasia of the papillodermal collagen.
This is really big.
Really big.
It goes really deep.
Really deep. Really, really big. Really, really deep.
Spindle cells.
Spindle cells. And they're straight as an arrow.
No, they're curved.
They're curved. Some might even say wavy.
Like neural.
And it's kind of loose and mixoid. So what do you think this is?
Nerve sheath.
No, nerve sheath myxoma are nested.
Trying to think of like I can't think of the words for the like DFSP version of the nerve version of DFSP.
Have a peripheral nerve sheath.
Yeah.
Not MPNST, but what grows like a DFSP but is a neurofibroma is diffuse neurofibroma, which is a disease-defining tumor for von Recklinghausen's. So diffuse or plexiform neurofibroma go very, very strongly with von Rex. They diffuse NF looks like an NF in any high power field, but grows into the fat like a DFSP. So overlying acanthosis. So DF, do you know any variant of DF that's composed of these funny plump epithelioid histiocytoma? Very good.
That was easy.
There's a crust, an acanthosis, kind of an LSC look.
Yeah, so it has an LSC look to it. In that, number one, you have eosinophilic necrosis of the granular layer, which is always fingernail work, associated with a crust, acanthosis, hyperkeratosis, and papillodermal angiofibroplasia with or without vertical streaking of collagen, lichen simplex chronicus.
So there's a lot of links at the DHA.
Okay.
Some red blood extravasation. I want to make sure it wasn't syphilis.
So do you think this, so if that's the staining of blood cells, do you think these are blood cells?
No.
Or those are dead reds?
I think those are dead reds from the lichenoid.
So it's a lichenoid interface dermatitis. And what else is in this lichenoid interface dermatitis?
Yeah, some EOs. So
you have some EOs.
A bite or something.
And you have parakeratosis. So could be lichenoid drug, could be benign lichenoid keratosis. Probably not lichen planus with the presence of both EOs and parakeratosis. Good.
It's like a fibrous papule.
Looks like a fibrous papule, concentric fibrosis around both vessels and hair follicles with or without stellate fibroblasts, angiofibroma, or fibrous papule of the face when solitary. And as far as I know, the group whose office is here, which is our now third years, I think you control the temperature in this room with your thermostat.
No,
We don't have a
don't
thermostat.
have
It's
a
pretty much a
thermostat.
closet.
Our thermostat is the door.
Yes.
Or check with Mark. I think there is a hidden thermostat that controls that room and this room, which are kind of
Maybe it's
tied
behind the
together.
bookshelf that Katie made.
Maybe it may live behind the bookshelf.
That's nearly made.
Still standing.
So, myofibroblast.
So myofibroblastic proliferation with vessels that run north to south and fibroblasts that run east to west. So dermatomyofibroma certainly has east to west running fibroblasts, but in this case, it also has the vessels that run north to south, which is more like scar.
Hyperkeratosis and
Hyperkeratosis, acanthosis, elastic trapping, and then what's happening there?
lymphocyte infiltration.
And is it leaving the epidermis alone or damaging the epidermis?
Damaging.
Damaging. So you've got an interface dermatitis. So you have hyperkeratosis, follicular plugging, PEH, and interface dermatitis damaging the basal layer. So open up to the room. Two things that could do this. Hypertrophic LE or hypertrophic LP. And how are you going to tell them apart? Direct immunofluorescence. So if it has a granular band, full house band at the junction, it's hypertrophic lupus. If it just has shaggy fibrin, it's probably hypertrophic lichen planus. So hypertrophic lupus erythematosus, important because more than half the patients have systemic lupus, and also important because it tends to drive squamous cell carcinoma formation more than other forms of lupus.
So, got diffuse infiltrating, like going down to that too.
Tell me about this vessel.
It looks pretty destroyed.
And what's in the middle?
There's fibrin in the middle.
Yeah, and what's in this vessel?
More fibrin.
And what's in that vessel?
Fibrin.
And what's in that vessel? And what's in that vessel? So what group of disorders might you put this in?
Is this like collagen vascular kind of thing? Or they're like fibrin or just LCV?
Or so it could be an LCV, but there's a lot of clot, right?
Yeah.
So maybe thrombotic disorders. So name some thrombotic disorders.
So you could have like antiphospholipid.
Antiphospholipid.
All the other ones we test for.
Protein C, protein S, antithrombin 3, prothrombin mutation, factor 5 Leiden, antiphospholipid. You go down your list of thrombotic disorders. Very good. How are we doing time-wise? Good, okay.
So there's some pigment normal brown.
Yep. Does it have only pre-existing collagen, or does it have its own unique sclerotic collagen?
I think it's its own. So
And is that a good thing or a bad thing?
It's a good thing.
That's a good thing. So this is probably Blue Nevis. Very good.
Very large specimen. We're all the way down to fat with the.
And tell me about the fat.
It's pretty much like single file.
Like single file lipocytes, which goes with DFSP. What's the brown stuff? Or what if it's melanin?
Oh, like a Bednar
A
tumor.
Bednar tumor. Very good. Someone pass the easy button over.
I've never
That was easy.
So Bednar is just pigmented DFSP. It's not every day you get to diagnose a Bednar tumor. That's pretty fun.
So we have a superficial vascular infiltrate.
Yep. And it's composed of
Neutrophils.
neutrophils. Are all the ants intact, or are there ant heads rolling about?
Been rolling about.
Ant heads rolling about, decapitated ants.
Euchorexis.
So there's karyorectic debris. So neutrophils, karyorexis, expansion of the vessel wall.
Vasculitis.
So LCV. And in this one, we can't see if it evolves deep, but we can see that your endothelium is completely intact. There's no endothelial necrosis. So name a group of disorders that would tend to do that.
Cutaneous small vessel vasculitis.
So it's postcapillary venal vasculitis of the little 5 group. So HSP, most drug-induced vasculitis, serum sickness, most connective tissue disease except for rheumatoid, cryoglobulin, thank you, mixed cryoglobulinemia. Whereas if your endothelium is necrotic, that suggests an ANCA vasculitis, septic, or rheumatoid vasculitis. And what drugs will give you an ANCA vasculitis? So propylthiouracil and anything that ends in Lucast are ones that tend to give you ANCA-associated vasculitis. And then levamisole necrosis as well gives you a P-ANCA commonly. Okay.
So it looks like it's kind of centered around the follicle.
Yep.
Looks like there's,
So what's happening in the follicle?
looks like mucin.
Looks like mucin. So if you see all that mucin in the follicle, then diagnosis not hard.
Follicular mucinosis.
Follicular mucinosis, yes.
If you get a read with follicular mucinosis, and should the pathologist tell you if they're concerned about CTCL?
Yes,
or?
they absolutely should tell you if they're concerned about CTCL or not. That is absolutely true.
This is split below. We have, I think, a subepidermal blister.
A subepidermal
There's some
blister
EOs there.
filled with EOs and some newts.
Maybe.
And if you look beyond it, we're looking to see if there are EOs at the DE junction. Don't particularly see them, but give me a differential.
Bullous pemphigoid.
So pemphigoid or so anytime you say pemphigoid, you have to say
Pemphigus. No, EBA.
EBA, because 20% when they immunoblotted all of the classic pemphigoid cases at UNC, they found that 20% were actually immunoblotting EBA. And those were the ones that were refractory to therapy, the ones that were associated with malignancy, all the baggage that goes with it were actually the EBA cases. And then I'd probably put bite in there also. Okay. Skip that one. This one and go to...
So we have a punch biopsy.
Yep.
There's some infiltrate that's more in the superficial dermis as well as the deeper dermis.
So it's patchy, perivascular, and also what part of the follicle? Is it more up here, down there, or in the middle? More like isthmus. What likes the isthmus?
Lupus.
Lupus. Does lupus give you follicular plugging?
Yes, it does.
Interface dermatitis?
Yes.
Mucin between collagen bundles?
Yes.
I think we're there. So, lupus.
There's hyperkeratosis, regular acanthosis.
Yep. Papillodermis normal?
No, kind of vertical streaking up.
And tell me about all this red stuff that used to be a granular layer.
It looks like it's been rubbed off. Like
Yeah, eosinophilic necrosis of the granular layer is fingernail work.
LSC.
Right. So LSC or prurigo, depending if it's a plaque or a nodule. That one was apparently a nodule because they called it prurigo. A cyst filled with vellus hairs. So in fact you see all the bundled vellus hairs there. So vellus hair cysts, which are often eruptive and multiple.
There is a melanocytic infiltration in the dermis.
Okay, good or bad?
Looks pleasant.
Very good. And so why do you say it's a pleasant?
It's like well circumscribed, it's small. It maybe appears to have different collagens.
Yeah, exactly. It has its own collagenous stroma that's different from the pre-existing dermis, which are all reassuring. When it is only trapping pre-existing dermis, that's when you're worried about blue nevus like melanoma.
Alright, so we have some cysts, a lot of cysts. Is that apricot snouting?
There's apricot snouting and Roman arches.
So, there's schmutz in there. It's not like a median orthe, is it?
So probably not. This is more the way apricot sweat looks.
Okay. So like hydro.
Yeah, and so what would be a hydrocystoma that's becoming an adenoma would be a cystadenoma.
I think there's something happening at the DEJ.
Yeah, first off, tell me how old the patient is.
Oh my goodness. I'm assuming
Is that
it's young.
is that thick pink collagen or skinny red collagen?
Skinny red.
So this is a member of the junior set, right? That's kid skin.
Okay.
So fair number of fibroblasts, skinny, very red collagen is kid.
Okay.
So it's kid skin. And then what do you have going on here?
It looks like a busy dermis, but it's a papillary dermis. I'm hunting for. Okay, there's interface change.
Interface change, and then are there holes out of proportion to lymphs, or is there a lymph in every hole?
Oh, I didn't see that. There's a lymph in every hole.
Lymph in every hole. So what do kids get that would have a lymph in every hole?
I mean, I don't want to give him MF.
So kids do get MF, right?
I know
They
they
get,
do.
especially black kids get hypopigmented MF.
Yeah.
There you would tend to see papillodermal fibrosis, which we
Yeah.
don't see so much. What else gives you a lymph in every hole?
If it didn't strike me as pleva. I thought it would have a lot more features.
So pleva tends to have a crust and lots of
Yeah.
red cell extravasation, but what kind of pityriasis lichenoides is not
PLC.
PLC.
Okay.
Okay. So pityriasis lichenoides chronica. So lymphadenary hole, MF, pityriasis lichenoides, early evolving BLK. Kids don't get a lot of those. And syphilis, don't forget syphilis, don't forget syphilis, don't forget syphilis. There is an interstitial busy infiltrate, so you might actually want to get a TPAL on this, even though it turned out to be pleva or PLC. Yeah. How are we doing time-wise? We got just a little more time. So subepidermal edema, a layered horn, compact with basket weave above it. So most likely thing you'd think of would be bullous but in this case you also have dead reds at the junction. You have some vacuolar interface. And this was bullous dermatomyositis. But bullous tinea would probably be the first on your list with that layered horn. So you get full credit for that. Even though you're totally wrong, but you get full credit for that. But you needed clinical to be right in that case.
Hypergranulosis,
Yep.
acanthosis.
And what are these vertical things within all that crust? Probably collagen bundles. So what would give you a fairly broad cup-shaped depression filled with debris and crust with vertically oriented collagen spitting out? So RPC, reactive perforating collagen, which can be inherited or can be part of acquired perforating disorder of renal disease. So perforating disorder, in this case an RPC or reactive perforating collagen type pattern. So vertical collagen bundles being spit out in a crust in a fairly broad cup-shaped depression.
Is that like a split, or is that? Looks like there's a lot of inflammatory cells. Maybe.
Yeah, lots of inflammatory cells.
Some not so nice looking cells.
And in there is also this and that and that and that and that and that. So sitting within an abscess, you have those structures, and probably the most diagnostic is this one right there.
I'm not sure.
Or that one right there.
It's like sort of fungus, I don't know.
Like a cluster of cells that looks very similar to what happens when an ovum becomes a morula.
Yeah, so
Prototheca.
yeah.
So protothecosis. One of the things that can help if you have a fluorescent microscope, Prototheca autofluoresces really strongly. Most fungi do not, but Prototheca really does. So that can be, sort of a cheap way to get to the diagnosis if you don't have Prototheca antibody or it's not growing yet in culture, especially if you're not sure.
So it looks like there's like lots of thickened collagen.
Thickened collagen down below with some infiltrates around the vessel. So this is
Maybe like a deep morphia.
like a deep morphia. Very good.
Punch biopsy, do you have nodules in your dermis? They look like.
And it's starting to form that and that and that and that and that.
Oh. I guess it's like whorls of collagen.
Yeah, so there are whorls of fibroblasts and they're starting to form this
Bubblegum pink.
bubblegum pink. Looks like bazooka bubblegum to me. So this is keloid. Yep. So hypertrophic scar turning into keloid. So you sort of have all the features here. Over here you have horizontally oriented myofibroblasts with vertical vessels like scar. Here it's become whorled like hypertrophic scar, and then it's forming keloid collagen. So it's gone through all the phases to keloid formation. Let's see. Got some reheats here. And we are at the hour, so I think we're done.
Right.